Welcome everyone to our webinar today on leadership strategies that improve workforce safety and well-being. My name is Brian Sexton. I'll be our host today. We are looking so forward to sharing these concepts with you. Please, before we get started, some housekeeping instructions. The webinar is recorded and will be available on the National Action Alliance website. You can use the chat function to engage with us throughout the session and to ask any questions. And there's also closed captioning available if you look at the bottom of your screen. Next, please, I want to say a big shout out to West Virginia University. That's Wheeling Hospital and Reynolds Memorial for making a commitment to join the Alliance. We encourage all interested healthcare systems to visit the National Action Alliance's website to understand the commitment process, which involves having an executive leader in safety pledge on behalf of the organization. Organizations may formalize their commitment by submitting it via email to nationalactionalliance@hhs.gov. Now, today, we're going to be talking about well-being informed leadership behaviors that promote well-being in workforce and promote patient safety amongst our patients. That's the first out of three. In November, we'll be talking about workforce burnout as a key driver of patient safety, and that workforce well-being is, in fact, patient safety. In December, we'll be talking about how to resolve the turnover crisis in healthcare as a way to drive patient safety in the right direction and help to simultaneously improve workforce well-being. We have a couple of additional announcements. If we go to the next slide, the Workplace Change Collaborative was funded as a technical assistance center by the Health Resources and Services Administration, HRSA. That was to support 44 different HRSA-funded grantees that were all focused on promoting healthcare workforce well-being and to create a national framework to advance new thinking and identify strategies to address burnout and moral injury. That framework, available to the public on the WWC website, it emphasizes organizations and system level changes, because threats to personal and professional well-being originate in or are compounded by upstream drivers. The framework aims to support efforts by organizational leaders, policymakers, workers, learners, and other stakeholders to address well-being in the workforce. One example of this HRSA-funded award went to Duke University, and it was the WellBe program, which I can speak to briefly. Next slide. In this program, we actually embedded bite-sized positive emotion doses of well-being into continuing education format. This was a series of randomized controlled trials which caused improvements in well-being that were bigger than the decreases in well-being that we saw associated with the COVID-19 pandemic. So it's 3 years of well-being getting worse relative to 8 days of the intervention that actually more than reversed that impact on well-being. It's available now. You can access it through the QR code that's on the screen. For this, we use the RAFT format. RAFT stands for research. We present the data. That's the research. A is for assessment. We ask you a few questions about your well-being. F is for feedback. We feed back your well-being. You get to step on the scale, look at your well-being numbers, and see how that. It's kind of like if you're going to diet, helps to step on the scale. If you're going to work on your well-being, helps to step on the scale. And then T is for the tool, because we give you the tool and the opportunity to use the tool while you're doing the continuing education. It's all baked in. Over 90% of our participants rated it positively. Next slide. All 4 well-being outcomes improved. That is emotional exhaustion, which is how we measure burnout; emotional thriving, how much are you flourishing; emotional recovery, how much do you bounce back after upheavals; and work-life integration. All improved. They all went in the right direction. That's really exciting. I can really emphasize 2 of them: emotional exhaustion and emotional recovery. Think of emotional exhaustion as how big is your well-being battery? Well, we made the well-being battery bigger. And then think of emotional recovery as how quickly can we recharge that battery when it gets drained. So we both made the battery bigger and we enhanced their ability to recharge the battery. And that's really exciting. So just like we can help individuals with microdoses of positive emotions in these continuing education formats, we've also shown the same thing with groups of people to share. Let's start with the leadership walkarounds as a strategy. If we can go to the next slide. Positive emotion microdosing. This is interesting. It happens when we do these leader rounding efforts. Now, traditional patient safety leader rounding takes place when you have a senior leader walk into a work setting and says, "So, how are we going to harm the next patient, and what can we do to prevent that?" That is a great way to surface patient safety and quality improvement related issues in 1999. In 2024, that's a great way to get something heavy thrown at your head. Instead, we've merged this awareness, this well-being awareness with the rounding, and we've created what's called positive leader rounding. So this is where the same leader walks into the same group of people, but now they say, what are 3 things that are going well around here and 1 thing that can be better? Now, what they respond to is like, well, here's what I'm grateful for. Here's something I'm looking forward to. I want to give a shout out to this colleague. And here's 1 thing that could be better. Now, by doing that, you actually grease the skids and make it easier for that staff member to talk about something awkward or uncertain or embarrassing with the leader, because you've created psychological safety. That is a theme that you're going to hear in both of our mini sessions today on this webinar. Psychological safety as the foundation to make this this transition of healthcare workforce well-being and patient safety both better at the same time. Now, we can go to the next slide. Just to give you an example of this, we actually put a horse race of traditional walk rounds relative to positive rounding. If we can go to the next slide. Both of them worked. So traditional safety rounding works. It works for safety culture, patient safety. It works for workforce well-being. But if you do the positive rounding format, where you're eliciting some good stuff right before you ask them to go into detail about the bad stuff, you have a bigger effect. You learn more in the positive rounding. They're more willing to share, and you have a bigger impact on not just patient safety climate, but also the emotional exhaustion of the workforce. It's really exciting. And if we can go to the next slide, what we're going to do now is ask you to go to the chat and put some of your thoughts into the chat. What specific strategies can healthcare leaders use now to improve the well-being of their staff, and what outcomes can be impacted by applying leadership behaviors focused on the workforce well-being? All right, I think we said we were going to go to slide 8, and I just went ahead and went. I thought that would be really good to stop here. Looking at how do you get senior leaders to come and walk through and ask provocative questions. Now, the traditional walk round frame, which we say, so how are we going to harm the next patient around here? What can we do to prevent that? And in 1999, that was a great way to start a conversation about patient safety and quality improvement. In 2024, that's a great way to get something heavy thrown at your head. So we have transitioned to a more kind of well-being centric way of eliciting important information like this, and that's positive rounding. And in that version, we say, tell me 3 things that are going well around here and 1 thing that could be better. And in this way, we get at the risk, we get at the issue that needs to be surfaced and addressed, but we don't do that at the expense of the well-being. We do that in a way that actually facilitates the well-being of the individuals that are involved. That's called positive leader rounding. If we can go to the next slide, you can see here too that we put traditional leader rounding in a horse race against positive leader rounding. Next. Both of these worked. And so what you're looking at here is basically a chart that compares positive rounding to traditional safety rounding. And both of them worked, but positive rounding, where we established these little micro doses of positive emotion, it worked significantly better on patient safety culture, on building psychological safety. And preview, you're going to hear more about psychological safety from both of our mini sessions today here in just a minute. But in particular, it really improved. It's associated with a big difference in emotional exhaustion, which is how we measure burnout in the literature. So by doing this leader rounding in a well-being informed way, we have a big impact on the well-being of the workforce. So with that, next, I just wanted to say, as we're launching into our 2 guest sessions today, please note in the chat, what are some specific strategies that healthcare leaders can use to improve well-being of their staff now, without having to wait for some vendor, without having to wait for some new technology. You can do this now. And then also, what are outcomes that can be impacted by applying these leadership behaviors on workforce well-being? Next. Please also share with us in the chat, what would you like to do differently or better to improve the well-being of your staff? And with that, I'd love to transition and move into our introduction of our first speaker. Dr. Alan Frankel is a high reliability expert who has practiced anesthesia, held senior administrative positions in hospitals, was a grant-funded researcher, started 2 companies, one of which was acquired by Vizient Inc. He has evaluated thousands of healthcare systems worldwide and run interventions in hundreds of these healthcare systems. He has shepherded many safety-related interventions into practice, such as culture surveys and quality assessments, and most recently using digital visual management boards. You're going to hear a little bit about that today. He's written 3 books and many articles, and I'd love to hand it over to my friend and my mentor, Dr. Alan Frankel.
Brian, you're incredibly kind. I have to say, I think I've learned more from you than the other way around at this point in our careers, but it's absolutely a delight to be here. And I think my role here is to set the stage for what our other 2 speakers, David Hurtado and Abigail Lenhart, are going to speak about shortly. So let me go ahead and do that, and I'll add that Brian has played a role in the development of many of these concepts. So leadership and the journey to highly reliable care, and how to achieve greater levels of well-being while also focusing on what we all want, which is the best possible care for patients at the same time. Next slide. Yeah, a quote or paraphrase that I've been using literally for a couple of decades, I think is an enormously powerful one to set the stage here. And this comes from Leonard Berry, who's a professor of marketing and who spent a couple of years evaluating an incredibly capable organization, Mayo Clinic. And he came back and he essentially said, operational excellence is dependent on the willingness of individuals to volunteer their effort above and beyond what they get paid. It's an enormously powerful statement for organizations to think about, because the question is, when and how will people be willing to volunteer their effort above and beyond their salaries? And a big piece of this is linked to the degree to which the individuals feel that their well-being is focused on by the organization. Next slide. I think my job is to kind of, again, paint the overview of how various kinds of rounding, senior leadership rounding, and these well-being interactions with frontline employees, where do they fit in the structure of highly reliable care? What you're looking at here is a framework that's been developed literally over 2.5 decades, almost 3 decades, by lots of very smart people, some through the Institute for Healthcare Improvement, and then through many organizations that we've worked with over the years, where we've said, what's the structure that needs to be in place to get an organization and the units within the organization to be successful? And this is kind of the picture that we've come up with. So let me just describe it to you very quickly. It's an elevator ride description of the framework that I would argue every leader has to have access to and be able to use as they participate in their work in an organization. And it goes something like this. Foundationally, cultures have to be healthy. Individuals have to be accountable to helping maintain those cultures. Teams have to know what kind of work to do. Just culture and psych safety have to be robust, as does respect and professionalism, and you have to have mechanisms for negotiating your differences. In that environment, you then collect knowledge, which is essentially defect identification and good ideas, so positive rounding plus what could be better. And you collect that information and then turn it into grist for your learning system in the orange, where you're looking at that information and then driving change, presumably with a skill set to do so using Lean or the model for improvement or the ADKAR ProSci processes. And in yellow, leaders have the skills which they bring to bear in the calendared activities with a particular perspective, a set of behaviors that they manifest during that period. And in doing so, they pull the levers on the cultural knowledge collection and learning system activities. And the management system refers to the structured activities that support senior leaders and frontline managers to achieve this activity. And again, some of these we'll talk about momentarily, these structured activities that David and Abby will describe in detail. Next slide. The goal, obviously, is that if you look at these component pieces, culture, knowledge, learning, and leadership, and you walk down into any unit, inpatient or outpatient, whether it's the operating room, a central sterilization, or Brian Sexton's office practice, or Dr. Lenhart's office practice, will you see all of them robust? And we know from the culture surveys that Brian and I have administered, in essence, to about 20% of the healthcare workers in this country, that you see great variability in how effectively leaders manifest the skills associated with the framework. And you see that visually here in some grayed out areas where you might not want your family taken care of, whereas you have other places that are enormously capable, with capable leaders, capable managers. In the next slide, ideally what we want is for every unit in an organization across the board to have the capacity to be self-reflecting and improvement capable. And in so doing, you then set the stage for operational excellence. You set the stage for Leonard Berry's comment that people will be willing to volunteer their effort in this environment more than they will be in the previous image in some of those units where the areas are grayed out and where frustration and emotional exhaustion begin to manifest. Next slide. Now, leaders play an enormous role in this. The robustness on the top refers to the strategic decisions that organizations make to support their senior leadership, to get these units aligned. And the supportive on the bottom refers to the ability to hear from people what the experience is like, to engage in positive rounding, for example, to understand how to support the units in order to be effective. And you learn from doing that activity on the bottom in order to make the strategic decisions you need to make robust on the top. And the degree to which organizations do this are incredibly variable. As we go in and look at organizations, this is a skill that needs to be focused on and developed in order to be effective. Next slide. Now, all of you on this call, if you're on this call, the leadership focus is on you. The robustness of the leadership activity is dependent on those people with titles of manager, director, VP, CXO of some type or another. Next slide. And by the way, that means that you really need to understand the component pieces of that framework. We know from studies that Brian and I have been participating in together and individually, how much of a difference leadership rounding makes. This is data that comes from publications around 2017 looking at Michigan hospitals. In essence, each of the three colors, blue, red, and green, refer to a domain of culture, cultural climate, learning, leadership, teamwork, safety, perceptions of burnout in yourself and in others. The blue refers to the average scores of people answering the survey. The green refers to individuals who participated in a leadership rounding and received feedback after the rounding process. And the red identifies those individuals who participated in leadership rounding and did not hear back, did not get feedback from their leaders. And what becomes readily apparent is that leadership rounding conceptually has to have feedback in it, or when you go and round, you actually make things worse. The people in the red columns perceive the world less well than the average in blue. Those in green perceive the world as better across the panoply of cultural climate because they feel like their voice is heard and that leadership are engaged with them. This is a simple but powerful example of the importance of leadership activities in organizations and how they're done. Next slide. We have lots of other data that kind of link to this. We know that as leaders are perceived in a better light, that those individuals have a 28% reduction in the odds of their feeling frustrated, emotionally exhausted, or ultimately burnt out. Next slide. We know that as we look in it with the digital visual management boards that we've brought into organizations, We can look at how many people participate in manager huddles and how long the managerial huddles are. And we see that there's a sweet spot that as the right number of people in a unit participate in the huddle, there's a decrease in levels of burnout in that unit. And next slide. We also know that as the percentage of huddles that should occur do occur, and that the huddles last long enough to be more than simply focused on operational issues, but also around issues of community collaboration and improvement, that perceptions of burnout improve in addition. So in 2024, we have an understanding about leadership activity and managerial activity that's becoming increasingly precise in our thinking about how we help to create a workforce that's willing to volunteer because their sense of well-being is where it should be. Next slide. Now, just I'll mention, because I now work for Vizient, and Vizient has all of the quality data for essentially all of the academic institutions in this country, literally 95% of them, plus another 1,300 of the community and rural hospitals in the US, that when Vizient looked at the best performing organizations from a quality perspective, they identified the same characteristics that Brian and I have been challenged over the last 30 years to characterize based on cultural health. So lo and behold, cultural health and operational excellence go hand in hand. The characteristics of how leaders and managers behave turns out to be essential if you want to be both operationally excellent for patients and culturally excellent for your workers and employees. And with that, I'll hand it back to Brian to introduce David and Abigail, who'll talk about one incredibly useful and important leadership rounding activity that helps to support the concepts that I've just described. Brian, I'll give it back to you.
Thank you, Alan. And can I just say, I love your description of the sweet spot and just the way that you interact with staff makes such a difference for their well-being. I hope we can loop back to that, and we are going to hear more about that from our next speakers. David Hurtado is an associate professor at the Oregon Institute of Occupational Health Sciences at OHSU. His research concerns workplace determinants of health inequities, especially for healthcare workers. And he's a principal investigator with Abigail Leonhardt of the Work-Life Check-ins, a NIOSH-funded workplace intervention to reduce burnout in primary care. I can't wait for you all to hear about this. He's also the PI of an AHRQ-funded intervention to integrate workforce and patient safety in rural critical access hospitals. David is going to go second. The first speaker is going to be Dr. Abigail Leonhardt. She is an associate professor of medicine at the Division of General Medicine at Oregon Health and Science University. She was the principal investigator of the study examining burnout in 25 primary practices in Portland, Oregon, and is the current co-PI of a randomized controlled trial. We need RCTs to show that this stuff works, of an RCT examining a burnout intervention. She currently serves as the wellness lead in the Division of General Medicine, Internal Medicine, and a chair of the Primary Care Wellbeing Work Group. And she's a member of the OHSU Wellbeing Leadership Team, leading systems initiatives to improve well-being. Please welcome Abigail to the stage.
Thank you so much for that kind introduction. And I'm delighted to be here today with Dr. Hurtado and Dr. Frankel to talk a little bit more about these leadership practices to improve well-being. And we're going to dive today into work-life check-ins, which is a practice that we studied that has been shown to help improve employee well-being. Next slide, please. So the objectives of our portion of this discussion today are to discuss the rationale and evidence supporting work-life check-ins, and we're also going to review practical tips on how to conduct these check-ins. Next slide, please. So I'm preaching to the choir here. Why is this important? We know that burnout is at epidemic levels across healthcare, regardless of profession. We know that leadership behaviors, from what Dr. Frankel just shared, as well as in other areas of the literature, that leadership behaviors really impact team member well-being. And in these financially fraught times and time with scarce resources, including time, leaders need practical solutions to improve well-being that can be implemented quickly. Next slide, please. So where did this come from? As mentioned earlier, I started a survey in primary care practices at my home institution, measuring burnout in all team members. And what we found was, in one of the practices, we saw an improvement in emotional exhaustion when everybody else was unfortunately getting a little bit worse. And I don't know if there was a question. I saw a hand go up, or if that was just an accident. I'll give that. I'll keep moving.
Keep moving. Thank you.
Yeah, we did a qualitative interview of that clinic to figure out what was going on, what was unique in this practice. And we found that a new practice manager had arrived and had started implementing these types of check-ins. We then did a feasibility study to see if we could spread this practice to another clinic. And unfortunately, or fortunately, the timing happened to be in the middle of our COVID-19 pandemic. And it showed that it was possible to spread this to a new practice, and in a hybrid environment where some people were working remotely and some people were in person. Next slide, please. So this is a graphic really looking at sort of the conceptual framework of what a check-in would look like. The goal is that a leader and a team member spend some time together. The team member brings concerns to that leader. Together, they can brainstorm solutions. These check-ins are confidential, so if the leader feels like this needs to go to a larger team, they would ask permission of that team member to bring it to that larger leadership team. That team could then, if needed, brainstorm solutions a bit more. The solution would then be implemented and monitored. And the next time the leader and that team member meet, they look at, does that solution need to be refined? And then address any additional concerns that get shared by that team member. Next slide, please. So what are the check-ins? The goal is that they are a 5 to 15 minute time where a leader can check in one-on-one with a team member. Vegas rules applies here, so what happens in check-ins stays in check-ins. These should be confidential and in a safe space. The goal is that the team member really drives it and brings anything that is impacting their well-being that they feel comfortable sharing to the table. Examples of what might be brought forward include things like life stressors, like childcare change and it's impacting their schedule, work stress, new workflow that's not working well, or something that can make the work experience better. And the goal is, in this time, that the leader and the team member identify a way to try to improve whatever it is that is impacting them at that time, and they problem solve together. Next slide, please. All right, this is a sample of what we are currently using now to train leaders to do these work-life check-ins. This is part of our randomized control trial that you'll hear a little bit more about later. And so it's a little bit different than what you might see in the paper that we published in the Mayo Clinic Proceedings on this work-life check-in. So again, before the check-in, you're going to secure a private location where the worker feels safe discussing their concerns. That can be via WebEx. It can be in person in a private room. It could be walking to go get coffee. You want to schedule those at least on a quarterly basis. We recommend scheduling for 15 to 30 minutes to give time in case there is something that is going to take a little more time to discuss. And then we ask that the leader review past meeting notes or any outcomes from previous solutions that you had worked on together. So during the check-ins, we ask the leader to start with an open-ended question. What would you like to check in about today? What's working that could be improved? And then listen and reflect back. So listen to what the concerns are. So it seems like this new workflow is causing you more work and stress. You will also spend a little bit of time following up on any unresolved issues from a previous check-in. And then the goal here is that you brainstorm with that team member, ask them what solutions they see, also be transparent if change is not possible. So if that solution isn't, or if this isn't a problem that you have the sphere of influence to address, that's okay. And sharing that you understand their concerns and will advocate where you can. I'm going to just highlight briefly what a check-in might look like with a real world example from one of our practices. So a phone room staff member and a lead checked in together. The phone room staff member said, hey, this new metric we have to try to get our patients in quickly for medication-assisted therapy. This is Suboxone therapy or buprenorphine therapy for folks who are struggling with opioid addiction. Is really challenging. We're not able to get them in the time frame that you have set for us, and it feels like we're being set up to fail. The leader said, gosh, thank you so much. That does sound really stressful that we've told you to try and do something and then you can't do it. Can you tell me a little bit more? And the issue was that there were not enough clinicians who were trained. This was back in the area of the X waiver when you needed to have a special license to be able to provide buprenorphine care. There weren't enough providers. And with permission, that leader said, brought it to their larger leadership team. And ultimately, they decided to train all of the residents that were in that practice to be able to provide medication-assisted therapy. So we're able to increase the pool of people who are able to provide that kind of care and reduce the stress for the phone room staff and be able to provide the care that the clinic wanted. Next step, please, or next slide, please. So after the check-ins, if you were the leader with that example, you would email a brief summary, say, Maria, thank you so much for sharing with me those concerns about trying to schedule these MAT appointments. I'm going to bring this to the leadership team. Let's meet again in 4 weeks at this time. You're then going to reflect as a leader on the concerns, any patterns that are coming up, logistical barriers, and with permission, discuss it with your greater leadership team, and then implement next steps. And I'm now going to turn it over to Dr. Hurtado for the rest of the presentation.
Thank you, Abby. We did a multi-method study, and we interviewed clinic leaders as well as team members to listen their experience conducting and participating in the check-ins. And the experience was rather positive on for both parties. For team leaders, it was important to literally touch base with each team member and see what was working and what could be improved. And from the perspective of the team leader, it was important to provide input and also to receive validations from the things that on a weekly or everyday basis were bringing frustration, stress, and were simply annoying. So the check-ins were very good to acknowledge those stressors and also to build trust with the respective team leader. We also did a quantitative analysis from the preliminary study that Abby mentioned at the top of the presentation. And we showed that the clinic where the check-ins were performed did better in terms of reduction of emotional exhaustion, perceived job stress, and more importantly, it also it helped to increase values alignment between team members and the respective team leaders. Next, please. So Abby just mentioned an example of workflow change as a result of the check-ins. But if you're curious to know what happened, what were the change produced by the check-ins, we learned that even though the check-ins were a one-on-one encounter, the changes were at the organizational level. And that had to do, for instance, with career path recommendations, particularly for workers who felt stuck or that they didn't see a career progression in their current position. So the check-ins was a good moment to discover resources and trainings available to team members through the organization or elsewhere. A big area was the facilitation of flexible work arrangements, particularly requesting time off or making changes to the location or the hours of work. Improvement to processes, particularly the workflows that simply annoying workers. That was a good opportunity for them to provide input since they have to do the work every day. And other area that was important brought up in the check-ins was changes to the work environment, particularly upgrades in ergonomics to the workstation that were affecting, workers, and they didn't have a chance to just to report those. Next slide, please. And even though the check-ins are a relatively straightforward and simple practice to start implementing, there are several limitations to take into account. And some of them we're trying to address in a current and ongoing randomized control trial that we are doing in 12 primary care clinics, and we're eager to present the findings once we have them. We're in the midst of collecting follow-up data. But what we learned from our work so far is that the big one is that while clinic leaders are doing check-ins, the risk of increasing their own burnout is also higher, and also especially if they hear concerns that exceed their level of power and authority that are system-wide problems. So that's one thing to take into account as a limitation for these check-ins. There's another practical limitation that sometimes it's just simply difficult to schedule the check-in, or there's not a good location. But for instance, in our trial, we're trying to mitigate that problem by providing trainings and templates and more resources to ease the scheduling and the performing these check-ins. And as Dr. Frankel and Abby mentioned, it is paramount to have psychological safety and respect the boundaries. Once you hear things that perhaps relate to the personal life or the family life of a worker, respecting boundaries and not making judgments about their personal or family situation is fundamental. And to address these gaps, for instance, we are developing more trainings to complement the basic instructions for conducting these check-ins. Next slide. But we strongly believe that this is a easy to implement and effective practice that most healthcare organizations can start implementing soon. And we think that the check-ins work in reducing burnout and emotional exhaustion because they provide an opportunity for team members to share what they like and what can be improved. It is a time dedicated to their well-being and not necessarily a performance review. So this is a way to demonstrate that leaders care about team members' well-being and safety. And something that is very important is that this is an opportunity for them to provide input about the things that can be improved, since they have to do that job every day, particularly when in healthcare there are many top-down actions. So this is a way to calibrate those actions with their input. And in quality and safety, this provides a forum, a quick and easy opportunity to put in motion improvement plans. Next slide, please. So this is the end of our presentation. We look forward to hearing from you. There's a link in the chat for from our current publication. I want to thank our collaborators and the National Institute for Occupational Health and Safety, NIOSH, who's funded this study through the Oregon Healthy Workforce Center. So thank you so much. And next slide has additional references. And yeah, thank you so much for your attention.
Thank you so much, David and Abby, for this what I think of as one of the coolest, most exciting new techniques to work on patient safety and well-being simultaneously that I've seen in a long, long time. It reminds you of the importance of having the workforce perspective elevated whenever you're going to do something to help patients and the workforce simultaneously, and you're connecting with them directly in a way that I just think it makes such sense. I love that you gave specifics about how to facilitate psych safety, like how you conduct them, how long they should be, how many they should be. And I just wanted to reflect very briefly that in the 24 times I've presented to leaders since I read your article, I've talked about how with just 4 quarterly check-ins, 10 to 15 minutes each staff member, it becomes an intervention, a well-being intervention for the staff member, that the leaders like it, that the staff like it. And I pause and I say, that means all of you managers are interventions. You are the intervention. We don't have a magic wand that we can wave right now, but every one of you leaders out there right now, you're the intervention. You are what we've been waiting for. I know that doesn't sound reassuring to hear that, but there's a light bulb that goes off when you explain it, and you've collected the data and you're doing the randomized controlled trials. It's so exciting to see that data. I just, as I said in the editorial about your work, it's like, watch this space. I think there's a lot more there to be mined and a lot more there for us to learn from going forward. Let's go ahead and go to the next slide. And just, I want to remind folks that please take this time to enter your questions into the Q&A. We'd love to hear what your questions are of our speakers today. And we'd also love to get this dynamic going back and forth between our speakers, who, before we came together to discuss this, we hadn't met each other. But I can tell that we are kind of cut from the same cloth in many ways in the way we think about how to measure this stuff and how to do this work and during challenging times in healthcare. Before we get started, are there any other comments that Abby, you or Alan or David, that you'd like to make before we jump into some of the Q&A, or do you have any last thoughts before we go into the Q&A?
No, I just want to thank you for your kind words, and thank you for helping organize this webinar. And we look forward to hearing your questions.
So, okay, well, let's just, you're very welcome. This is my pleasure. I love sharing what you've done with others. It's just been, I've got 3 slides in my standard slide deck that I give everywhere, and it's just y'all's work, and I give it everywhere I go. Let's jump into some of these questions. How do you recommend to do this when you have larger staff, like a hospital where you have a nurse manager may have 50 to 100 employees? I know at Duke we have a neonatal ICU that has over 400 nurses that work in that one enormous NICU. Logistically, what are your reflections on how to deal with that?
Yeah, some of the clinic practices that we work with are 180 people plus. And what we recommend is having a whole leadership team. So my guess is the nurse manager also has charge nurses or other people who are in a leadership role within that unit. And so the goal would be that you have that whole team of people who then meets with the team members. So in some of the practices, we'll have a nurse lead or a back office lead or a front office lead, a practice manager, and the people will meet with one of those leads. The key is that it really should be someone who understands the levers of sort of change within that unit. So if it's someone who understands, oh, this is the issue that's coming up, I know where to take this. It shouldn't be someone who doesn't have that sort of sense of how to make improvements in the space. But you're right, one person cannot meet with 50 to 100 people. In most of the practices, they are taking about an hour a week to try to do these check-ins in the larger practices. And in a smaller practice, it's much less time intensive. So hopefully that helps answer that question.
And we automatically have these fleets when we have large work settings, fleets of charge nurses and others who could ostensibly, be chipping in to help with this important work. We have another question here. What are the tips to convince leaders to start working on workforce safety and well-being? How would you start with, in this case, they said with 50 staff, a small organization with lots of politics? I know that's rare, that never, politics don't exist anywhere, but just hypothetically, how would you start to do this if there were politics and you didn't have the infrastructure? Where would you start?
I can jump in, or yeah, go ahead.
This is related to the prior question where, the first thing is identify your teams, and get a sense of who leads, which team members. One thing that I was going to say relative to regarding the previous question is that in larger practices, you also want to practice the check-ins with like team leads or charge nurses, those informal or in between type of leaders, to just get a sense of the check-ins before you roll them out to the rest of the clinics. And in regards to this this question about where to start, assuming that there's no, you can start. You can start with one individual team member. I think that's if you start this practice with the check-ins, and by that I mean I'm opening the door for 15 minutes where you can bring up whatever is on your mind, whatever is bringing joy, whatever is bringing you annoyance or stress. Then I will take it from there. And I think what we learn in our study is that the check-ins does two things: identify the things that leaders can change, and if they can change it, then they should put a action plan in motion with the input from the person that brought up that problem. And there are many techniques for quick, short QI rapid cycles. But if the things cannot be changed because they exceed the power or the authority of the leader, the check-ins are very helpful in acknowledging and validating that stress. I think it's a good way to demonstrate that you hear, that you heard them, that you listen to them, that you know that this is an issue. And that's, if you cannot change it, at least that we've learned that can help reducing emotional exhaustion from the team members' perspective, because they felt listened.
Yeah, Brian, I'm thinking out loud about this. The whole concept of how you make change in an organization, I think, applies to the question you asked, or the question that one of the participants asked about, how do you get people to start doing this? I think if you're interested in this kind of process, positive leadership, well-being, rounding, there's two ways of thinking about it. You can look around and say, well, my organization is not that interested in this. And so David's comment, I think, is germane, that says this whole concept of diffusion of innovations, innovator, early adopter, late adopter, historian. What you want to do is you want to go to the innovator or early adopter running a unit and say, would you participate in doing this? Here's a great idea. Give it a try. We'll give you the support we can, but you get to test it in an area and then showcase the impact of it. On the other hand, if you have organizations that are interested in this on a larger scale, then you can say, all right, how do we think strategically about how to go about this? That doesn't change the fact that you'll go test it in a place where someone wants to do it first, where you can showcase the process, but you are at the same time beginning to set the stages for growth across the organization. So part of what you need to do is say, what's the appetite in my organization to do this? And based on that, where might I go and start? And the only rule of the road from the diffusion of innovation theories is, don't go to the hardest place to institute this. Go to the place where people want to work with you, test it there to get it right, and then use that as the mechanism to grow it in the organization.
I love this. We're having many more questions come up in the chat, so I want to ask this, and we can all kind of respond. There's this question. A couple have come up that basically pose this idea: I'm the leader. I'm supposed to be helping with patient safety and well-being, but I'm super burned out. How am I supposed to, in my burned out state, go and help these folks with their burned out state? And so I just would anyone like to speak to that? And I'm happy to speak to that as well.
Brian, I think we should give you the opportunity to start. I mean, David and Navi, I don't want to take, if you have comments, please, but that's right down your alley.
Well, for what it's worth, I think if you're a leader and you're not burned out right now, I'm kind of worried about you because a lot of the bad stuff seems to float up, and we don't just hear about all the great things from people that report to us. We hear about all the things that are not going so well, and that accrual can cause a lot of burnout in our leaders. When we, in a pre-pandemic study, we were looking at burnout in North Carolina hospital presidents and vice presidents across the state of North Carolina. This is before the pandemic. This is in 2017. We actually saw it was almost 80%, 77% of those senior leaders reported burnout before the pandemic. So this is a common problem. I think something that I heard David hint at this, and I've heard Alan, I've heard you hint at this many times, is you get something out of this as a leader. When you are doing something that reminds you of why you became a leader, because I want to help people, I want to see the look on their face when they feel relieved that I'm carrying something that they just shared with me. Maybe I can't fix it, but I'm carrying it with them. And the next time they talk to me, they know that I remember what we talked about last time. That helps with psychological safety. That helps them feel seen and heard. And we know from 50 years of research in psychology that it's not that you do support me. It's that if I feel like you would support me, even if you wouldn't, if I feel like you would support me, that has a protective factor for my stress level and for my well-being. And so what you're doing is and I'm not saying that you should just fake it. I'm saying the leader as the intervention is good for the staff and it's good for the leader, because you tick that purpose and meaning box in a really direct and relevant way. It's not a lot of time that you spend on it, but Tracy Goslin, who did the positive rounding at Duke, she was our chief nursing officer at the time. She's fantastic. And she was a co-author on the paper, so I feel very comfortable kind of like outing her in this example. She said, my favorite hour of the month was when I got to go and do the positive rounding. And I asked to do more, and they had to tell me to back off. So it becomes part of what reminds you why you wanted to be a leader in the first place. But let me just kind of pause there and say, I don't know if anybody else wants to chime in about what business does a burned out leader have doing burnout interventions with burned out staff?
Yeah, I'll take a stab at that. Thank you. I wholeheartedly agree with what you shared, Brian. I'm going to talk maybe specifically around the check-ins. I will say that there's a sense of efficacy that can happen when you actually make a difference, right? In the life of your team member. It's a little bit of the quote we often attribute to Teddy Roosevelt, which is do what you can with what you have where you are now. So we may not be able to fix all of these big systemic issues. Like I don't have millions of dollars to increase the staffing levels in my hospital, but I have the ability to make things a little bit better in the environment that I'm in for that team member. And so that can give you that sense of power and hope when there's often the sense of helplessness, I think, for some of these big systemic issues. The other thing I would say is our leaders do find that team members really like to feel heard. And so that can be in and of itself, that sense of validation is great. And it, again, not necessarily addressing those big systemic issues, but just saying we're on the same page. I totally agree with you. I'm advocating for where I can to make this change. Makes a big difference. And then the other thing we've been doing with our leaders is reminding them they aren't a psychologist. So if someone is coming to them with pretty significant moral distress, injury, really severe burnout, depression, those things, we actually have a list of resources. Here's EAP. Here's how you get to these other places, because we're not asking them to do therapy. We're asking them to help point people in the right direction if that's where that person is. So I think having that as a frame of reference, like I'm not actually here necessarily to fix my coworker's depression, but I can point them to the direction for where they can get help for themselves too. So I think there's risk there, and we're working on mitigating that risk so that you get that joy from that efficacy and making an impact without feeling like you have to take on the burden of everything that's been shared with you.
I love that answer, Abby. Your job is not to become a therapist for your staff. Your job is to just share with them in understanding what their challenges are with respect to well-being and seeing the common humanity in that in a way that, and I think we can all learn from Brene Brown's kind of playlist of how to be vulnerable in a way that's appropriate with others. Not overly vulnerable, but vulnerable enough to invite them to be vulnerable back. And just to reiterate, one of the things that we do when we equip our leaders to go into units is we give them what's called a stack of coping cards. It's kind of like a 5x7 a card that has a list of resources on the front and the back with QR codes and phone numbers. Same resources I'm sure you're talking about, like here's our EAP program, here are links to resources that you can tap into for individuals and for groups as well at the health system level. And part of what you're doing is putting the coping card in their hand and saying, if you want the resources, here they are. Here's why I'm here today. And then you kind of go from there. I think it's really excellent to have all that packaged when you approach a staff member to have one of these check-ins, just so that you're giving them something while you're sharing with them in that vulnerable moment. So we're going to go ahead and wrap up the Q&A real quick. I just thank you, all of you, for sharing your research and your time and your perspective with us. I wanted to make sure that we have a chance to get, and please feel free to continue to put information in the chat as we go forward. Just in closing, I want to let you know about some upcoming events that we have. Our next National Action Alliance monthly webinar, we can go to the next slide, is going to be on November 12th, noon to 1 Eastern time. That one is on understanding that workforce well-being is patient safety, and what we can do about that. Please stay tuned. That's going to be a wonderful fireside chat format with Dr. Colin West. We're really excited to share that. So please stay connected with us. You can subscribe to the listserv. You can email us at National Action Alliance at hhs.gov. That's also where you can go to join the coalition. And with that, I just want to thank everyone for joining us today. Thank our speakers and thank everyone for joining, and thank you for your engagement and your questions. We can't wait to see y'all next month, same bat time, same bat channel. Thank you, everybody.